Thanks for taking time on a Wednesday evening to be with us. We'll try to make it at least modestly entertaining and certainly hopefully informative. Again, I'm Peter Fecci, and Joe Neimat's my counterpart, who at least on my screen is kind of right next to me, hopefully the same for you. So begin with the standard disclosures. There are a lot of cases here that both of us will present that are our work. The rest of this is nothing that I have to read, but here they are regardless. We each have some disclosures of our own. Both of us are obviously consultants for Monteris, which mostly involves talking about the uses of the system. And that will kind of lend its way into my first portion of the talk. So the first portion here will be just a LITT technology overview and kind of what the technology is and how we start thinking about using it. So obviously the goal here is a thermal ablation of lesions. LITT stands for laser interstitial thermal therapy. And the idea of using heat to treat disease is admittedly not new. In fact, it's really one of the oldest of medical therapies, dating back to even the time of Hippocrates, with the quote from Hippocrates you see here: "Those diseases that medicine do not cure are cured by the knife. Those that the knife does not cure are cured by fire. Those that fire does not cure must be considered incurable." The notion of using heat to treat cancer and other things has been around for thousands of years. But this is really, of course, the first time that we have it in the technology package that you're going to see here. So what is LITT? First off, the most important thing to know about is that this is a minimally invasive procedure. Typically, when we do this procedure, our incisions are 1 centimeter or less and require just a couple of stitches at the end. I typically use an absorbable suture. And through that small incision, which is essentially the same as one would use probably for a biopsy, we introduce stereotactically a probe or a catheter that has a laser diode at the end of it. And what you can see on the right here is that with the Monteris system, or NeuroBlate system in particular, there are two types of diodes that you can have. One emits heat only in one direction, and the other has a 360-degree emission. So the one on the left we call side fire, and on the right we call a full fire. There are different advantages and disadvantages to each. They're a little bit beyond the scope here. As a tumor surgeon, I tend to use the side fire exclusively, and we can talk a little bit more about that later. We have a robotic control attached to that laser, so we can change its depth remotely, and we can spin that laser if you're using the side fire to essentially sculpt a lesion from internally. The procedure is done in an intraoperative MRI suite at Duke. A diagnostic MRI suite works just as well, although you have to transfer the patient from the operating room where the laser is introduced to the diagnostic scan, which is where the thermal ablation takes place. And basically the system uses MRI thermography to essentially convert the MRI into a giant thermometer, converting phase change data into temperature. And the software package converts that temperature data into zones of kill and stun, and allows us to cook the lesion from the inside out. Again, most patients it's a minimally invasive procedure. Most patients tolerate very well, and in my case, I almost never put a patient in the ICU, and during COVID times have increasingly begun to send patients out on the same day. At the worst case scenario, typically it's home the next morning, particularly if it's a later in the day surgery. There are two options. We will be talking about comparisons between those two systems. That will mostly fall on Dr. Neimat. But there's the Monteris NeuroBlate system, and Visualase has a system as well. The key differences from my perspective are the directionality of the laser that one can employ, and some of the technical differences Dr. Neimat will get into further. The MR thermography we talked a little bit about here. There are zones of kill and stun. You can see here there's a white line, blue line, and yellow line. Blue line really means that the tissue here is dead. And yellow line, the difference between the yellow line and blue line is kind of a penumbra of reversible heat damage. Dead means the equivalent of 43 degrees Celsius for the equivalent of 10 minutes. Kill is really a function of time and temperature. So if you increase the temperature, it requires less time to kill, and vice versa. And it really works off of essentially a modified Arrhenius equation, which you see here. But essentially, that's how the software package calculates those zones. The mechanism of kill, this is a busy slide, is really just heat damage. So it's the laser light itself does not penetrate the tissue very far, usually only about 2 millimeters or so. The heat, however, goes out to a radius of about 1.5 centimeters as far as being able to kill tissue. And so it is that heat that is the actual mechanism of kill and not necessarily the laser light per se. Typically, this says lesion diameter of 4 centimeters. I would say that 3 centimeters is probably a little bit closer to accurate as far as how large a lesion you can reliably kill on a regular basis. With that kind of introduction of the technology and the mechanisms of cellular kill, I'm going to turn over the next section to Dr. Neimat. Are there any initial questions before we proceed on that section?
So I'm going to have a brief technology overview and talk about the different systems that are out there. So at this time, there are two systems. Oh, sorry. There are two systems in addition to the NeuroBlade system. There's also Medtronic's Visualase system, and it's to me that these systems really came about at almost exactly the same time. If you look at sort of a timeline of these two companies, they were both started in the 90s with really a similar idea, and it sort of brings to mind to me the idea of the adjacent possible, that essentially you had technologies that had been advanced to the point that they made possible this sort of juxtaposition of explicit imaging and MR thermography and laser radiation, and it suggested to two separate companies independently this idea of using them together for this particular application. So you can see Visualase Biotech was first founded by Ashok Gowda, who I think did this as his graduate PhD student thesis. In '98, they received significant grants and got NIH funding to develop this MRI-guided laser system. The first cases were done in 2006 by that group in Paris, and the first commercial use was in 2007. The first procedure in the US was in 2008, and it was applied to epilepsy in 2010, which is my particular area of interest. So Richard Tick and Mark Torchia developed the first prototypes for this, again in the 90s. The first trials in man were in 2008, again, almost exactly at the same time. That trial was completed in 2009. 2010, there was commercial use of NeuroBlade for tumor, I believe, at first. And the first application for epilepsy was in 2014 at Vanderbilt. It's gone on to win a Principal Innovation Award and Gold Medal Medical Device Excellence Award. Just recently, this year, Richard and Mark Torchia received the Pioneer in Technology Award for the Society of Brain Mapping and Therapeutics. So it's been a very rapid rise of these two systems. So some of the differences, so they are both compatible with traditional stereotactic systems, whether those be frame-based, mini frame-based, like the one I will show you that we use, or robotic insertion, etc. The probe sizes are similar. Visualase makes a 1.65 millimeter probe, which can be used with stereo EEG bolts, the larger size of those. NeuroBlade has two sizes. There's a 2.2 millimeter probe or a 3.3 millimeter probe. The 3.3 can also have a side fire directional property. The bolts are a little bit different. You can see them here. The Visualase bolt is kind of twisted into place over an alignment rod. The bolts for the Montera system are driven with a kind of a T-handled screwdriver that fits into your frame and is very secure. And then again, there's the Visualase has only a diffuse tip. The Montera has both full fire and side fire properties. Here you can see some of the technical differences in the MR thermography, and in the laser. So Visualase, they're slightly different wavelengths that have different properties. The Visualase is 980 nanometers versus 1064. It tends to heat a little bit faster, but be a little bit less exactly controlled. Visualase is a constant energy, whereas NeuroBlade is pulsed with discrete energy settings, you can see here. They are cooled by different mechanisms. So Visualase is cooled with a saline pump that circulates fluid through the catheter that contains the fiber optic laser, whereas NeuroBlade has this CO2 cooling tube that cools the tube more rapidly. The visual lathe is inserted by hand. The robotic probe driver is used for Monteris, which drives it and can be used to control it remotely from the control room. I think one significant difference for NeuroBlate technology, which is not understood, is that there's phase drift in your MR thermography in scanners, and most systems do not take account for that. The Monteris was very thoughtfully designed to essentially look at all voxels and measure temperature and look for a drift in those voxels, and then estimate it and make a correction so that the temperatures that you're seeing and your prediction of ablation is more accurate. And so that's a significant property that is kind of seamlessly integrated into the system that you wouldn't know unless you were sort of made aware of it. So I think that is an advantage. So this is an example of some of the views that you have. NeuroBlate has software that asks you to look for these particular 8 points of reference on each of 3 consecutive axial scans, or scans perpendicular to your trajectory. And then these calculations are essentially calculated throughout the procedure, and so that there are adjustments being made, as I mentioned. And again, some of the software differences. So visual aids really temperature monitoring only based on the points that you select. You can pick points and have a software feature that will shut off if you achieve a certain temperature that you set. The NeuroBlate has an internal temperature sensor, which is important. It looks for overheating at the tip of the laser. There are multiple pick points that you can select, and those are designed also to set sort of warning thresholds that you can do, and then future software then will have the ability to shut off automatically if that's desired. Something that I really think is important, that the visualization that I've seen with visual aids, and we use both here, it's limited by 2 planes that are perpendicular to your orientation of your probe. And so that is useful in some procedures, depending on the location of your lesion, but in many procedures, I think that's not adequate. And you may miss something that is not easily visualized in those particular planes. With NeuroBlate, you have multiple options for both anatomical planes, but also a series of perpendicular planes to your probe that allow you to see just more precisely what you're potentially heating. And I think that's very important. And then, as we spoke before, the probe movement is manual with visual aids, where it's robotically controlled by the software with NeuroBlate. And here, this just shows some of the images from each. So this is the visual aid software that allows you to kind of see how this temperature is occurring. And then there's this is sort of the illustration of the Arrhenius equation that is showing you what has been ablated. It's not terribly clear how that relates. You'd have to sort of see it side by side with the other axial scan there, or coronal scan in this case. Here with visual aids, with NeuroBlate, you're able to see the growing volume of your ablation as it progresses, and it's just a little bit clearer. You also get to see it in multiple coronal sections here, as well as anatomical sections shown below. Okay, thank you. Yeah, this is just an illustration, a chart showing those various differences. Most of these we've talked about. I don't think there's anything here that's significantly that wasn't covered previously. Any questions about any of what I've presented?
I'll simply reiterate that I've used both systems. I learned both systems, and we trialed both systems. And for me, with Tumor, it was just impossible to see all the areas that I needed to see to make sure I was being safe with the visualized software, particularly if you're up against an eloquent area. There's just no way to see what you're doing kind of at your back door a little bit, and it was a little bit nerve-wracking. So I'll echo those experiences. So I'm going to talk a little bit about the tumor side of things, since that's really where I specialize, and what some of the uses of LITT has been in the tumor field. What you see here are kind of multiple areas where LITT has been used in general, gliomas, radiation necrosis, metastases, MTS, which is on the epilepsy side, of course, and then some other uses. And I'm just really going to talk about the tumor uses here, of course. So I think part of the problem with LITT is it's just like everything. You know, you have a new toy, and I think the issue here is that once you have a new tool, particularly if it's a hammer, everything starts to look like a nail, and we've all heard that analogy before. And the trick is that sometimes you get a screw, and clearly the hammer is not the right tool here. So it becomes really essential if you're going to use this safely and adequately to make sure you're pulling the right tool out of your toolbox. And LITT should be viewed as just that. This is not to replace all the techniques that you've learned. This is really just another tool in your toolbox to use when it's appropriate. So that means you have to understand what some of the limitations are. So what are those? Well, first off, talked a little bit about the fact that I think 3 centimeters is really a pretty reasonable diameter limitation for a lesion that you can cover with a single trajectory. Now, you can use multiple trajectories to cover larger lesions, but you have to remember that you're not taking this out. It does tend to cause some swelling. So if you're in an area where swelling is a concern, you want to be careful there. And if you're dropping 2 trajectories for a larger lesion, you may be causing more swelling. So about the largest lesion that I've ever treated and felt comfortable with is about 3.5 to 4 centimeters. And that did involve 2 trajectories. We don't know that the extent of coverage target, you know, is it 90%, is it 100%? There are some literature out there, retrospective, that actually implies the same kind of thresholds that the Nader Sinai and Mitch Berger papers in glioma show, which is that once you get to about 80%, you start to see a meaningful impact. The heat is not specific for tumor, although you'd be surprised at how much more quickly sometimes tumors and areas of necrosis heat than normal brain. So you have to be careful, obviously, as you push the heat out, that you stop once you get to the tumor border. It does cause some edema and mass effects, so we do tend to need some steroids postoperatively, hopefully not for too long, and that's one of the major advantages. Superficial lesions do create some artifact, the bone, the dura, the bolt itself, and so it sometimes becomes hard to see, but we've become increasingly better with new techniques of shallow bolt placement, et cetera, of being able to see those superficial lesions to treat. And then heat sinks is another thing to keep in mind. I call this the rule of V. So water has a very high specific heat. If you're heating near water, it's going to be tough to get things to the temperature you need right at that border. So ventricles and vessels, those are the things that contain fluid. And if you're trying to kill a tumor right along the border of one of those, you may have a little bit of trouble getting that last little margin along that to a sufficient heat. Obviously, you have to be cautious about your trajectory planning, and then there's a learning curve associated with the technology, of course. One of the big problems is neurosurgeons, right? So we're like a kid in a candy shop. You just gave us a laser. You gave us sharks with frickin' laser beams attached to their head, and we're going to want to use that toy. And sometimes we use it forgetting that this is still a pretty powerful instrument, and we can cause some damage. So you have to be aware of some areas where you want to push a pause button. This is, again, not for every tumor. So we talked about the rule of V's, a periventricular lesion like this on the left. This was a lesion I treated with LITT, actually. It did eventually recur. You just have to be aware that there are some areas along CSF spaces that may not quite get to the temperature you want, but you may still be able to get 95% of the lesion. Superficial lesions, this was a lesion that maybe used to give me pause, but now with kind of some techniques that we've adapted, I think these are increasingly okay. The one on the right, this is a no-go. A large lesion near the brainstem, you're just going to cause the kind of swelling that make the herniation that you're starting to see there already worse. This is someone that should be resected, as it was in my case. So what are some of the uses? Well, I think it's key to remember that there are some gold standards in the way we treat a variety of tumors out there. For GBM, that's typically surgery plus Stroop for a newly diagnosed tumor. And for brain metastases, that's often going to be SRS plus or minus resection. But even if though there's some gold standards in the therapies, there are some areas where there are no gold standard, some areas where the treatment standard is a little bit less clear. For GBM, that's patients who are ineligible for Stroop, and that can include the elderly, patients with a low KPS. That's probably about 30% of presenting GBMs, frankly. And recurrent tumors, where the standard of care is less obvious and less decided and agreed upon. Keeping in mind that in GBM's case, that's going to be essentially 100% of those tumors. And if you're going to do a surgery on those folks, you have to be aware of things like poor wound healing, limitations of being able to operate through Avastin, radiation-induced wound healing, et cetera. And then there's also some tumors that might be suboptimal for resection subjectively. Maybe there are deep lesions in the thalamus, areas where you may not feel comfortable going with an open surgery. On the metastatic side of things, there's patients who fail SRS, which is about 5 to 15%, depending on the institution and measurements. And those folks also who have had radiation are going to have potentially problems with wound healing. They may have reached their maximum radiation dose. And of course, on the flip side, if there's 5 to 15% that have failed SRS, there's essentially equivalent numbers that get radiation necrosis from multiple or even a single treatment. And those patients often have few viable options and suffer the side effects of long Decadron usage. So these areas where there's no gold standard become areas where you can see employing new technologies and trying to narrow the therapeutic window for folks who might be riskier for open surgeries. So moving along, what my goal here now is to show you what some of the standard of care are for some of these tumors, and to produce for you some examples of where LITT might fit in, where that standard of care becomes less clear, or their role of an open surgery may be less obvious. And I think it is key to note here that what LITT really is an alternative to is it's an alternative to your method of cytoreduction. It's an alternative to the open surgery. This is not an alternative to radiation or other technologies. It's just another surgical tool for obtaining cytoreduction.
Which stereotactic systems can be used for LITT?
Yeah, so, and I'll let Joe Neimat also kind of pipe in as he wants to. You know, we typically use the frameless systems. So, for instance, we use a VariGuide system, which is the BrainLab system. I know that there's like I think it's Vertec for Medtronic. So there are, but you wouldn't want to use this. I guess you, in theory, could try doing something like a CRW frame. We really tend to use the frameless systems for this, and they work very, very well. I often, because I want my trajectories to be fairly accurate, you know, we have some certain luxuries available to us where I am, and so I tend to use an Aero CT to register for BrainLab rather than doing facial recognition, just because that intra-op CT can be super accurate. We fuse that CT with MRI, and then we use the Visualase system as our stereotactic kind of guidance. Joe, do you have anything you want to add to that?
Yeah, I think that laser ablation is really agnostic to the type of stereotaxis you use. It certainly can be used with the sorts of frameless systems that you described. I've used it. I primarily use it with the Starfix platform, which is a mini frame. It's certainly been used with CRW and Lexel frames, as well as robotic systems. I know at Emory, Bob Gross is very fond of sort of pairing it with ClearPoint, so you can even use it with the intraoperative MRI-guided stereotactic systems. I think any of those work. You just need an appropriate fitting between your stereotactic system and the bolt driver that you use for the different devices.
He says, compared to SRS for a similar lesion, do you find edema/mass effect is better versus worse? How long of a course of Decadron do you normally prescribe?
Yeah, I would say it's probably comparable. It may be a little worse, at least acutely. It depends a lot on the size of the lesion. I typically have gotten to a point where I put people on an 8-day taper, like a 4Q6, 4Q6, 3Q6, 3Q6, 2-2-1-1 taper. A lot of it really, I think, you have to think about where the lesion is, how big it is, and whether that person is coming in on steroids because they're symptomatic already. The longer someone's been on steroids, I think the little bit longer the taper tends to be for me. There are folks that I can get off in a 2, 3, 4-day taper, no problem, and there's folks that need a little bit longer. I don't think it's a one-size-fits-all. I think you're going to have to pay attention to things like lesion size, location, and symptoms.
I'm curious if you pre-treat with steroids in patients who have not been on steroids. I have not, but I'm always curious to hear other people's practices.
I give them 10 times 1 in the OR.
I do the same, and then a 7-day taper. So.
Yeah, so it sounds like pretty similar.
Yeah.
But I do think it's important to recognize there is definitely swelling with this, and it's important to understand that. So, okay, so moving along, if that's okay. So some standards of care for newly diagnosed GBM. We're familiar with this maximal safe resection if able, and then Stroop protocol if able, if KPS and age permit, so temozolomide and radiation.
He said you mentioned the need for Avastin as a potential situation where this may be better than open surgery. Could you speak to bleeding risk in these patients with LITT?
Yeah, so we have now done over 100 cases, and I have never had a bleed from the laser. I have had a bleed from the biopsy, which then precluded the laser, or at least did not allow us to get as good coverage, because as you can imagine, the laser doesn't work very well underwater, or under blood for that matter. The Avastin, we have pushed the envelope a little bit more. So typically I would not be willing to perform an open surgery for about 4 to 6 weeks after Avastin. We have done it at the 2-week mark, essentially, which is kind of what our policy would be for a biopsy on Avastin treatment. And so we're essentially treating it like a biopsy risk for bleed. So the key question here is if able, and that's what I want to kind of talk about. But before kind of going into a little bit this, I think it's important to review the Stoop protocol as well, and understand kind of what this was and who benefits from Stoop. So if you go back to the original article, which was in the New England Journal in 2005, again, Stoop is basically just radiotherapy plus temozolomide. It was compared to radiotherapy alone, and patients had undergone either a biopsy, partial resection, or complete resection as eligibility for this study. And the reason that this is important is that it was not everybody that actually received benefit from the Stoop protocol. And if you go back through the original paper and read through the text and look at the charts, what you'll notice is that people who underwent biopsy only, or who had a KPS less than 70, or at least a poor performance status, actually got no additional benefit from the Stoop regimen. And then folks that had only a partial resection, as you might suppose, got only a limited benefit to Stoop. And so the fact is that if you're not achieving cytoreduction, if you're not actually removing the tumor or killing a tumor pre-radiation and chemotherapy, there really is no additional benefit to the Stoop regimen. So what can be the role here in newly diagnosed GBM as far as a role for LITT? Well, not everyone's able to get the standard of care. So not everybody is able to get resection and Stoop. And then who doesn't get resection? Well, it's the folks that either get biopsy or partial resection only, like we just talked about. And that might be folks with difficult to access lesion. It might be folks who are elderly or have low performance status. Oftentimes there's, the kind of peek and shrieks that a lot of you are familiar with, where someone says they took it out and tells the patient that, but really just did an open biopsy. But the key thing here is that if you can biopsy, you can often LITT. Because if it's safe to drop a biopsy needle down that trajectory, it's safe to put the laser down there as well. Someone seems to be controlling my mouse. Anyway, the fact is that if you're only biopsying folks and you're not offering them cytoreduction, they're really not receiving any benefit from the Stoop protocol absent that cytoreduction. So when you think about it, the folks that you're biopsying only, or who are you're only partially resecting, those might also be people that could benefit from the cytoreduction that LITT would offer if it's something that might be safe to pursue. So an instance of that might be something like this. So this is a patient with a newly diagnosed GBM. This is, as you can see, kind of into the corona radiata and then starting to border onto the basal ganglia here. And the issue is that this is someone that you probably wouldn't be all that excited about going in and resecting with an open surgery. Not surprising, this person was a bit weak preceding this. And what you can see is that using kind of DTI imaging, you can thread the needle through white matter tracts with a biopsy needle and a laser catheter, and you can cook this quite safely. And this person did very well after surgery, frankly. So what are the key points here in newly diagnosed GBM? If you're only offering biopsy, and I think in a lot of instances that lesion that I just showed might have been a biopsy-only patient, and so that can be as much as 15 to 30% of patients, the Stoop protocol survival benefit is obviated. You're really not giving them any benefit to treatment. But if you can safely biopsy, you can often frequently offer cytoreduction via LITT, which is the goal of your surgery in the first place. And so areas where biopsy only is the path you've chosen might be an area where LITT fits quite nicely into your treatment algorithm. And this is, again, for specifically newly diagnosed GBM. If you move into recurrent GBM, I think actually the possibilities open up quite a bit more. So this is i.e. after patients have had surgery and Stoop regimen, come in with radiographic progression. The trick here is that there's really no standard of care, and that I think is a big hint. So first off, 100% of GBMs essentially recur. Are you going to offer them resection? Are you going to offer them Avastin, more chemotherapy, clinical trials? Really, there's no kind of standard algorithm here. And so what about surgery for recurrent GBM? Well, nationally, there's only about a 14% reoperation rate. A lot of that's dependent institutionally. There are some institutions that offer it almost as a knee-jerk, and there are some that rarely offer it. But ultimately, whichever your practice is, it's always a balance of the goals of surgery and the risks. So the surgical therapeutic window is clearly smaller in patients with recurrent GBM because there's an increased risk of redo operations. And some of those risks come from poor wound healing. If you're going to reopen a craniotomy incision following radiation, that's always a concern. Oftentimes these patients are a bit fragile or sicker. And again, we talked a little bit about Avastin, which might preclude surgery for 4 to 6 weeks, but perhaps less so for LITT. Benefits of surgery for recurrent GBM, well, they're the same as they kind of typically are. We know that we might be able to reduce mass effect if you're doing resection. If you're getting a biopsy or a resection, then you can use that for inclusion in tissue-based autologous trials. If you're making, let's say, a vaccine from the tumor or something similar, you can sample that lesion for targetable mutations. And potentially, looking at retrospective data, there may be increased survival for surgical resection or cytoreduction. As an example of that, this is just an example of some of the data. There are a number of retrospective studies looking at this, but the Director trial is one that's fairly well known, and there's another paper in 2016 as well. But the key point here is that when we look back at patients that got gross total resection for recurrent GBM, amidst those that got reoperation, the survival was better in those getting complete resection versus those that were incomplete. Key point here, of course, is that there's the bias of indication here. You gave a complete resection to those who you could, and so you really can't trust retrospective data all that much, but certainly it does seem to imply that there's a survival benefit to re-resection when able to do so. So what are the LITT opportunities in recurrent GBM? Well, it's very clear. 100% of GBMs recur, and there's really no standard of care for those. And the risk of a large surgery on someone who's been radiated where the lesion is scarred in, there's increased risk of that surgery, and it's often no fun. So if you could offer someone cytoreduction, which I think as a surgeon, we all kind of agree that that's probably beneficial, and certainly retrospective data seems to bear that out. And you could do that through a smaller incision with less risk to the patient, and kind of re-broaden your therapeutic window. This is potentially a real excellent use of the laser, and it's certainly an area where at Duke we use the laser quite frequently, is in folks that may not have other clinical trial options and have a recurrent GBM and might benefit from some increased cytoreduction and have a small enough, focal enough lesion where this is beneficial to them. So what are the key points for recurrent GBM? Number one, 100% of GBMs recur, and there's no standard of care for these patients. Resection, open resection is not a standard of care, and surgery, if you are going to do it, is really typically no fun if it's an open resection. Another key point, many patients will get biopsy to establish recurrence and obtain tissue for testing. If you can safely biopsy, you can often offer cytoreduction via LITT, which is really the goal of surgery. And last key point here is that many fear the risks of a big surgery in this population, although data suggests that there may be some continued benefit to cytoreduction if it can be accomplished safely. I would argue that a minimally invasive procedure like this would be one way of offering that. So I think you're starting to get the picture of what I'm going to present to you, which is that in general, we have standards of care that this is not meant to replace. But there are a lot of areas where it's a bit grayer, and this seems to fit very nicely, and we've had great experience with that. So, going back to GBM as a quick review, lesions that are deep and are inaccessible, lesions that are recurrent, those are really, really good uses of the laser, and we have a lot of experience now using that on the glioma side of things in those instances. Going into the metastatic lesions, we'll do that same kind of division of newly diagnosed metastasis versus kind of radiographically progressive metastasis, which then breaks down into either recurrence or radiation necrosis.
Dr. Fecci, thank you. Great talk, by the way.
Thank you.
So in recurrent GBMs, if you have a lesion that's in a non-eloquent area and it's relatively small, will you actually set up a larger than like contrast enhancing treatment field, like potentially encompassing the flare surrounding that lesion, or no?
An interesting question. It goes back to that point of, there isn't a classic prospective extent of resection or extent of coverage literature here, but I would employ the laser the same way you think about surgical resection. And if you have the practice of trying to be super marginal with your resection, go
Okay.
beyond the contrast enhancing area into some of those T2 bright, flare bright areas. If you're in an area that's safe to do that, I think I would employ the laser much the same way. It's going to be a little bit harder to do that in general because you're a little bit limited by lesion size here, and you're a little bit limited by the edema you're going to cause. But if you're somewhere like the right frontal lobe, I would say go to town.
All right. Interesting. I like it. Thank you very much.
Yep.
Given glioma's infiltrating nature, what kind of contour or margin do you aim for in these lesions? And how often do you find these results in worsening deficit when near eloquent tissue?
Yeah, so very good question. Along the same lines, if I have viable tumor on biopsy, if it's not, let's say, a radiation necrosis case, which we'll get into, I'm absolutely trying to take that blue line, which is the kill line, out to the margins of tumor, which means out through the kind of contrast enhancing areas. And as noted by Zach's question, if you can go beyond that safely, sure. I think if you're right up against an eloquent area, like if you're nestled right in the motor strip, for instance, this is an area still of equipoise for me. I'm still trying to understand for recurrent lesions in particular, where, in an open resection, you're gonna have to strip a recurrent tumor off that white matter, and it's scarred, it's radiated. That can be, pretty tough to do without getting a deficit for recurrent lesions. Obviously, it's a bit easier for like a newly diagnosed MET or GBM. I think you have to be worried about pushing that, too much heat beyond that border. And you may be a bit more conservative there of just taking the yellow line to the lesion edge against that eloquent border, or something between yellow and blue. We are in the process right now because I don't 100% know the answer about what's better when you're nestled right in the middle of an eloquent area like motor. Is it better to go in there open? Is it better to go in there with the laser? What's the rate of deficit from each? Obviously, surgeons' hands are, which surgeon is performing the procedure matters. But we are in the process actually right now of going retrospectively through at least my own data on when I've done open surgery versus laser for recurrent lesions in the motor areas, which turns out to be kind of a better thing from a deficit perspective. So I would say stay tuned. But I would say that I have had some patients where I did the laser right in the motor area and they woke up stronger than when they went to sleep. And I've had the opposite happen as well. And so I am cautious in those eloquent areas where we're right up against it. And I'm less willing to take that blue line right to the edge there. I try to be a little bit more conservative there to prevent that kind of a deficit.
Any experience with posterior fossa tumor ablations? If so, what is max size and any complications?
Yeah, great question. There's at least one paper out in the literature, a single institution experience with that. I have only begun more recently, and I've been doing it for about 5 years, to feel comfortable with that. I wasn't something I started doing initially. I've done 2 of those in the last few months, and I'll tell you that I'm still very conservative with that. Just like I would be very conservative with some large lesions sitting in the uncus. The 2 lesions I've done were both about 2 centimeters. They were hemispheric and not immediately adjacent to the brainstem. There wasn't tremendous mass effect preoperatively there. And the other thing is that you have to remember that, well, this is gonna be a little bit harder to explain. So if the head's going into the magnet, the cables need to come out of the head kind of towards the magnet in some way. So if you imagine going in let's say a prone position, head into the magnet, if you're operating on the posterior fossa, oftentimes you're coming from inferior to superior with your trajectory, and your cables are going this way, and then have to make a 180-degree turn into the bore of the magnet. And that's just a technical limitation that you have to be aware of. In general, these kinds of surgeries, it's not like a crania where you want the lesion at the top of your field. Oftentimes, people are pretty straight supine so that the cables can just come straight out this way, and you can biopsy obviously from any angle and laser from any angle. So the positioning is a little bit different. So that's an issue for posterior fossa lesions. So what I've found is that most of the posterior fossa lesions I've been willing to do are the ones where I can keep that patient, supine with a bump like this, which means for the most part trying to come from a retrosigmoid approach. And then this way, if it's like that, it can kind of come out and just turn a little bit into the magnet bore. So the 2 lesions that I've done so far in the posterior fossa recently have been retrosigmoid approaches with the patient positioned supine, which is an easier way of actually avoiding some of those technical limitations. And I do worry about swelling, so I've limited myself to about 2 centimeters so far.
I just want to echo what Peter said. We did a very similar case with a small pontine lesion just a week or so ago, and very much the same approach, sort of a retrosigmoid approach trajectory through the cerebellum. It can be done, and I was sort of struck by, it was relatively easy and effective. I do think this question of how much do you treat becomes even more concerning when you're in very high stakes territory like the pons, and it's a little hard to know and control where your yellow line is, and things we assume are. To comment parenthetically for those who haven't done a lot of this, we think of the yellow line as being the first border at which you might be doing permanent damage, and the blue line an indication of where you almost certainly have done permanent damage. And so knowing where those are and tracking them in real time is especially sort of delicate in those areas, but it can be done. And there are some series that demonstrate it nicely.
Did you go through the MCP for the pontine lesion?
Yeah, so that's exactly what we did. The location of this was such that that seemed to be the easiest access point. There have also been reports of actually treating a pontine lesion through a transcortical route, transfrontal route like that of a relatively large pontine tumor. Different ways to approach it. In this particular case, we felt like the easiest way to get to it was transcerebellar through the middle cerebellar peduncle.
The one thing I would say is before you run kind of guns blazing into the ponds, I would recommend getting some experience with the technology first. I mean, that would still scare the shit out of me a little bit now, but people have to push the envelope for us to learn what we can do. I've been a bit more conservative, but I am starting to push that envelope more and learn that with more comfort with the technology, what can be done safely. And Joe's obviously an expert user as well. I've done hypothalamic hamartomas with great success, actually, and that's actually a very good use for this technology. So,
yeah, I would say we approach very cautiously. My tumor partner Brian Williams and I did this together, and I think we were both terrified doing it. So, yeah, certainly I would not be cavalier checking these things out.
Yeah. So, oftentimes people, Monteros will show us someone's first case and it's like some 5 centimeter thalamic lesion. Don't start with that. That's just not where you want to start. So
it says for patients with suspected GBM in which you are pursuing biopsy, as example, low KPS or a tough area, is your workflow to go from biopsy directly to LITT based on frozen, or do you come back at a later time?
No, I think that's the huge benefit. You just replace that biopsy needle with your laser catheter right off the frozen. And I mean, for the most part, the only reason you wouldn't cook something is if it was, the alternative was kind of a non-tumor diagnosis, like, MS or something, right? Although who knows, maybe that works for that. But I think the simple fact is that, even if you're looking at, say, radiation necrosis, the laser treats that very, very well, because it's really not just necrosis. It's an inflammatory process that the laser, for reasons we don't fully understand, does a pretty good job of knocking out. And we'll get into that in a second as well here. So yeah, give them one surgery. And then one of the benefits to this too is that if you're sitting on someone who, they've progressed after treatment and you're not sure if it's radiation necrosis or recurrent tumor, the beauty here is that now you've got an excuse to do an early biopsy because you can treat that, whichever the result, and then you get an answer more quickly. And if you find out that the answer is that someone's got recurrent tumor, rather than sit and try to give them steroids and see if they get better, you're going to have an answer soon enough. And we know now from our own retrospective data that if it is recurrent tumor, coming back in with more SRS is synergistic with the laser. So if it's a MET, for instance. We all are familiar with the standard of care for newly diagnosed brain metastases. It's going to be radiation versus the combination of radiation and surgery. We all know, I think, at this point, the factors favoring each. So I think I can kind of skip this. So I think the key point here is that, again, if you think about laser as an alternative to resection, who doesn't get resection, where that's the standard of care? Well, it's people, again, with difficult to access lesions that are deep or eloquent. or patients who are getting SRS instead of surgery. And the fact is that SRS is a tremendous standard of care for newly diagnosed metastases. And if you have a deep 2-centimeter lesion that's difficult to access surgically, that's a MET, SRS is still going to be 90 to 95% effective against that lesion and can cover it. And if it's like a 4-centimeter lesion that you don't feel comfortable going after, laser may still not be the best choice for something that big and deep. So I really have to say that this is not the best application for LITT. You know, most METs are resected quite easily if they need to be because they're large or in an eloquent area. And the laser is going to, if it's in an eloquent area, may cause some swelling. And if it's not an eloquent area, it's an easy resection. And if it's, you know, too deep or small to access, you know, SRS is going to be pretty effective anyway. So there's just not a great obvious use for laser for newly diagnosed metastases. Maybe something that's, you know, 2.5 centimeters and is sitting in the basal ganglia. But again, same issue, or the thalamus, same issue. You know, why not just SRS that, which we know is fairly effective? So not the best application for LITT. Most surgically appropriate metastases are easily resected, and most surgically inappropriate metastases are treated with SRS with an 85 to 90% local control rate. So this is an example, like I said, of one case that I did for newly diagnosed metastasis. You can question, it's a little bit gray, but this is a patient that came that had 2 lesions. That were 2 big dominant lesions that were symptomatic. One that was a recurrent lesion in the right frontal lobe, and one that was a recurrent, this was, I think, a new lesion in the basal ganglia. And so I resected through an open resection the large right frontal lobe lesion, and then in the same sitting, kind of thread the needle here between the splayed corticospinals, which you can see on the DTI images there, and was able to get, you can see very good blue line coverage on the right of that as a post-op kill zone. And that patient was already weak, which is to some degree why I was willing to do this. And the lesion never recurred in that area. She eventually passed away about 6 months later from her systemic cancer, and she had not had recurrence at that site that was treated with the laser. So key points for newly diagnosed brain metastases really is just that this is really not a great use. The opportunities would mostly be for, let's say, a deep solitary or dominant metastasis that is difficult to access and in the 2 to 3 centimeter range. But again, you really could consider just SRSing that instead. So that's newly diagnosed. Happy to pause for any questions there, although I'd probably advocate for kind of pushing.
Yeah, let's go ahead, and I don't see any additional ones at this point.
Somebody seems to have control of my mouse, but okay. Anyway, so moving along to the next area here. So that was newly diagnosed metastases. This is radiation necrosis or recurrent metastases, either one which are the same, or different sides of the same coin, which is what happens when you see radiographic progression after treatment for these lesions. Let's start with radiation necrosis. This is where I began using LITT 5 years ago. So about 10 to 15% of SRS-treated lesions, you get similar statistics for failures or recurrence after SRS. Typically, you're going to see this about more than 6 months after treatment. And the options for treatment are, if you notice, are all things for the most part that are anti-inflammatory: dexamethasone, Avastin, hyperbaric oxygen. It's often treatment refractory and progressive. I often describe it to patients as a rash in the brain, you know, that like a radiation-induced rash that might respond to steroids and might not. And the key thing is that on a standard imaging, it really is indistinguishable from true recurrence and progression. The nice thing about the laser is that it's able to address either biopsy result, whether you have progressive disease, radiation necrosis, or both. So some common misnomers, and I think it's important to remember this. You know, Rhode Island is not an island. Acoustic neuromas are neither acoustic nor neuromas. And radiation necrosis is really a bad name for this. This is an active inflammatory process. Necrosis is a misnomer. People ask, well, why would you cook dead tissue? It is not. There's a viable region of inflammation that is spreading from that point forward in the brain. And just to drive home the point here, you know, that it's really difficult on MRI, and really there's nothing great for distinguishing the two. You know, this is a way of looking, you know, where would you see the tumor in this? This is kind of my version of Where's Waldo, top or bottom. In this case, it's on the bottom. Same thing here. Which of these is tumor? It's the bottom. Which of these is tumor? Bottom. Which of these is tumor? You notice the trend, so I'm going to trip you up top. The point is you really can't tell the difference. And so biopsy becomes a really important part of distinguishing these. It's really the gold standard. And if you can drop a biopsy needle in there, again, you can treat them. And you can offer them cytoreduction for progressive disease, or you can zap the process if it's radiation necrosis. And so this really becomes an important part of the treatment algorithm. One of the biggest things that's a disaster is there's folks out there that will just assume that everything that progresses after progression is true disease progression. They won't biopsy, and they'll offer more SRS. And if it's radiation necrosis, that's going to make things substantially worse. And then they'll simply conclude that that patient has no treatment options and put them on hospice. These are terrible treatment decisions. Getting a biopsy of this person and figuring out if it's something that can be treated easily is really the best treatment plan for them. So radiographic progression, whether it's radiation effect versus progressive disease, LITT opportunities. LITT addresses either diagnosis effectively, and it's a minimally invasive alternative to what can be challenging open surgeries. Again, radiated, stuck, scarred lesions. LITT permits concomitant biopsy, which provides tissue diagnosis, and it permits appropriate subsequent treatment. You know, if it's progressive disease after the LITT, we now know that we should give further SRS. It's better than either treatment algorithm alone. Many are treating presumptively without a tissue diagnosis. That can lead to treatment delays, or it can even worsen the condition. We all know the side effects of steroids. I will tell you that we have good data now showing that if you're going to manage radiation necrosis with steroids, using the laser is at least as effective and gets people off of steroids much more quickly. You avoid all the side effects that you see here, and you also prevent yourself from knocking out their immunotherapy, which is now increasingly becoming a standard of care treatment in metastatic disease. So LITT offers a huge advantage over steroids for treatment, and it also offers advantages over Avastin, which has a lot of side effects, and in patients with metastatic disease, risk of things like PE and clot are huge. So these are all things to consider. One key thing that I think is really important to understand is what patients' imaging will look like after the laser. So this was one of the first patients we treated at Duke back in 2015. You'll notice some of the specs here, which should make you be a little impressed by what happens here. This is an 80-year-old man with a history of non-small cell lung cancer. He had a left frontal met, which you see here, that had been resected and SRS twice. He was presenting with weakness, aphasia from a different lesion. And this was his pre-op scan. Now, this is what you need to know, is that at the 1 to 2 month mark, you're going to typically see that lesion increase in size, and you're going to get a thin rim of enhancement like what you see here. This is classic. We are currently working with our radiologist to design kind of our own type of RANO for this, essentially, that allows us to determine true progression after the laser. But this is a pretty classic course. And at 6 to 9 months, you start to see a retraction of the lesion. When I initially saw this, I got worried that we hadn't done any good, but there was a continued retraction of that lesion into a scar. And here's a guy that's 80 years old, and he already has brain metastatic lung cancer, a year and a half out. He has no lesion to be contended with here. He looked very well. His weakness had improved. And I can tell you that actually he just died 2 to 3 months ago, 5 years later, at the age of 85. So that's pretty good. You can see more rapid resolution than what I've just pictured there. You can see somebody here where by 5 months the lesion is actually gone. So some key points here. Again, for progressive disease versus radiation effect, LITT may permit early diagnosis via biopsy. It can address either biopsy result or even the mix thereof effectively. It's less challenging than an open surgery on radiated lesions, and it retains benefits for wound healing compared to craniotomy. And it can be a good alternative to prolonged steroid or Avastin used for radiation effect. That can get those people off steroids, essentially licensing their immunotherapies. So this is a summary of the LITT fit. I know we took a little bit of time here. Hopefully the discussion was useful. Newly diagnosed GBM, I think the best place for the laser is in people with deep or difficult to access lesions, or potentially in those who are a bit more fragile or elderly, folks that you might consider just biopsying, presuming they have a small enough, focal enough lesion for the laser. Recurrent GBM, really, barring the limitations of the LITT from size or location, really all these patients are eligible. Newly diagnosed metastases, maybe deep, difficult lesions, but really I think this is the toughest justification. Recurrent metastatic disease, progressive disease, or radiation effect, really this is a great use. This is where I'd say 80% of my usage is. and probably 2/3 of that is radiation necrosis. Really, there's, barring the limitations of the technology, it works great. So as long as you have an appropriately sized and located lesion, this is a fantastic option here. So recurrent lesions, radiation necrosis, and deep or difficult to access lesions that are less than 3 to 4 centimeters. This is kind of your money shot for the laser, and this is where we get kind of the bulk of our uses at Duke. So I think there's just 1 or 2 slides here I'll just show very quickly. Monteris wants you to be aware, and I would like you to be aware as well, that the registry called Lantern, which has been going on now for a couple of years, multi-center, tracking the outcomes of patients with tumors, now well over 200 patients registered in Lantern, and looking at their 12-month outcomes. We do have some results. This is published, but some key points here. You can see some really good survival. Now, this is not broken down by newly diagnosed or recurrent tumor, but it is broken down by primary and metastatic. And in either event, you can see 70 to 75% 12-month survival for these folks. And keeping in mind that there's recurrent tumors mixed in there, that's pretty impressive. If you look at the usages here, you can see that recurrent high-grade glioma, recurrent Mets, these are 2 really key accounts for more than half of the usages in tumor. And then the key things that we talked about. Basically, people mostly go home overwhelmingly. They tend to go home in approximately a day. I think the mean in the study, or the median, the average was about 32 hours. And that accounts for early usage when people used to keep these people longer. Again, we have same-day discharges now. 30-day readmissions, 1.8%. That's really low. Stable or improved KPS, more than half. And same is true for quality of life measures. So really a minimally invasive technique for tumors that has good efficacy, good outcomes, and really lets people kind of get back to life sooner. This is a great use of cytoreduction. This is a great tool for that in the appropriately chosen patient. And we're doing kind of probably 35 to 50 cases a year now for tumor at Duke. So, all right, any questions I can answer about that? Hopefully I got through that quickly enough.
And this question is, can you talk a little bit more about the temp recording software some more, the phase drift, and is there superiority in temp calculation between NeuroBlate and Visual Ace?
Yeah, I can speak a little bit to that. I mean, the NeuroBlate system, it's just much more active. I believe that Visual Ace, if I understand it correctly, essentially takes a measurement at the beginning. It assumes that the temperature that you enter into the computer is the base temperature throughout the procedure, and then it calculates any heating and cooling relative to that baseline temperature. On the other hand, the NeuroBlate system is calculating 8 points from each of 3 consecutive slices and tracks those throughout the procedure and is making adjustments all the way through. So it is, I believe, precise, much more active system. You know, whether that has a significant impact, I don't know that there's been a randomized study to demonstrate that there's a difference in the size of the ablation. But I have found that useful, particularly in patients who, in some of these patients we find, because you're down in the MRI suite, we have the situation where we do not have an intraoperative MRI, and so we have to transport these patients, and we're very mindful about their base temperature. We often find that they have cooled in the course of being in the OR and then being transported, despite our efforts to keep them with bear huggers and that sort of thing. And so I think in those circumstances, it can be an important differentiator that you're able to track the temperature more precisely, and that's being used to estimate your lesion.
One is, how often do you use Avastin? And then I'll come back to the second one.
So Avastin is a standard of care for us for recurrent GBM. It is not our standard first-line agent for recurrent metastatic disease, or for radiation necrosis for that matter in metastatic disease. There are institutions where Avastin is a bit more of a frontline agent. So I think it is a little bit institutionally dependent. We use Avastin mostly for people who kind of have very few other options with metastatic disease. Kind of they've maxed out their radiation, they have high disease burden, they're symptomatic. and there's really not much else to be done. So we're trying to provide them some symptomatic relief. Obviously, for recurrent GBM, it's still a pretty standard of care.
So I'll be speaking a little bit about epilepsy and the use of LITT in that disease. I'm going to try to move. We leave a bit of time for questions at the end. I always like to start these talks, talking about the patients. Something that I really enjoy about epilepsy is just how gratifying it is to see these patients. I advise my mentors early got started to all patients who have epilepsy to keep in touch with you, to send you postcards and emails every year on the anniversary of their surgery, because that's how you learn whether you may not be following them, and how do you know whether or not your surgeries have worked. And that's really paid off. So this is a patient of mine that we did an epilepsy surgery, and then a year after his surgery, he sent me this picture. He'd always wanted to go scuba diving and was down in the Caymans, swimming with stingrays. I've had other notes like this. If I can show you that. These are just some comments that I've received over the years from different patients. If I can, I think it's important to just think about in considering LITT. What are you comparing this to? What is the surgical situation in which you would treat a patient with epilepsy, and then how does LITT compare to that gold standard, similar to what Peter discussed in Tumor? And the gold standard for epilepsy really is this study on temporal lobectomy by Samuel Wiebe, where he demonstrated that if you randomize patients either to a surgical group or a medical group over a period of a year, you saw that the patients who received a temporal lobectomy for their mesial temporal epilepsy did substantially better, about 58% being seizure-free after a period of 1 year, whereas only 8% in the medical group achieved seizure freedom. And so that really is the gold standard that we have to measure ourselves against, and 58% is often quoted. There were later series demonstrating higher ranges, 70% often quoted, but 58 was sort of the first of these studies that explored this and explored it in a randomized way. At the same time, a temporal lobectomy has some morbidity. So there is significant neuropsychiatric morbidity, including deficits in memory processing, visuospatial and verbal reasoning. There are also significant psychiatric disturbances, including transient depression and anxiety. This is something that I sort of learned over time as I kind of learned to ask patients about them. Often you see a patient, you see their incision going fine, it's healing up, and they're not having seizures, and you say, thank you very much, you're done. It was only after several experiences of people telling me, gee, I'm really depressed and I don't know what to do about this, and understanding that that is a normal part of that surgery. Most patients do recover, but it can be significant, and it's something to keep in mind that has really motivated a smaller resection or ultimately an ablation. I'm going to go quickly through some of this development. This is sort of historically, we went from doing temporal lobectomies to selective amygdala hippocampectomies that just target the hippocampus, amygdala, and parahippocampal gyrus. These are those surgeries. I won't go into this at all. And then, move through this. Again, there are significant advantages to a smaller resection demonstrated in improved neuropsychiatric outcomes. Ablation really started before the advent of these laser systems. First in the 1970s, this paper by Narbayashi, who was seeking to treat psychiatric disease with amygdala ablations, found that seizures were no longer occurring in these patients. And this was followed by several other studies that this before there was really the ability to track this in real time. Importantly, this paper by Andy Parent demonstrated that small ablations were not effective, but that large ablations, in these cases, he was approaching laterally through the temporal lobe and doing as many as 34. And sure enough, he got an angle outcome, 1 or 2 of 60%, which is substantial, but he ultimately decided, and this was his conclusion, I think I can see here, if it will show. His conclusion that this just wasn't a great technique at that time, given the sort of the equipment that he had at his disposal. he did not feel that this was the best way to control seizures. So that really changed as people, became more thoughtful about their approach. Coming down the barrel of the hippocampus was demonstrated by this check to be more effective and to allow for larger ablated sequentially across the ends of the hippocampus. And then this paper was based on the visual aid system published by John Willie and Bob Gross. And what they demonstrated in their group was that about 50% of a group of 15 patients were able to achieve angle 1 outcome. And in their small series, those patients who had mesial temporal sclerosis, which is known to be a good predictor of outcome after temporal lobectomy, had a higher percentage of angle 1 outcome, 67%, approaching 70%, which seems to be sort of a magic number for epilepsy surgeons. And there were similar studies that followed this. This one out of Jefferson that reported on 20 patients, again, about a 50% angle 1 outcome. This study was very important. This was a follow-up to the study at Emory. And what they demonstrated is when they examined what had been now 19 patients who had received LITT and compared that to a series of 39 open temporals, both selective amygdala campectomies, they found that no patient with LITT had a significant decline in their specific testing of a naming task and a face recognition task. On the other hand, the great majority, 32 of the 39 patients with an open resection, experienced decline in these measures. And so that really is, I think, the reason that has recommended, the laser ablation for mesial temporal seizures over open resection, that you can achieve the same or nearly the same outcome, but with substantially less morbidity in the neuropsychiatric realm. Okay, I missed one paper, but in any event, you get the idea. So, here is a demonstration of the LITT procedure as we perform it. You saw the images. That's the kind of frame that we use. It's a variation on the star fixed frame. So this was that study again by Chen Wu. This was a series of 11 centers in the U.S., all of whom were performing laser amygdala hippocampectomy with multiple systems, not just the Montera system, but also the visual aids. And what they demonstrated in a total of first 234 patients that underwent the procedure, their efficacy percent, which again is identical to the percentage of angle 1 outcomes achieved in the Weeb study, but 58% were seizure free. This number was essentially persisted out to 24 months, which is great. You also had 70 to 80% of individuals who were achieving angle class 1 or 2. So really a very significant outcome. It's curious that in this group there was not a significant difference between patients who had mesial temporal sclerosis or those who did not, despite the fact that this is a much larger group of patients. Again, 234 as compared to studies of up to 20 in other centers. So this was a nice finding to look at. The other thing that was really interesting about this, they applied an imaging process where they essentially morphed all of these scans onto a standardized brain space. And this is a software that I was involved in at Vanderbilt that we used for DBS. But they applied this essentially to the shape and size of the lesions that were performed in the hippocampus. And what they found, if you went voxel by voxel and sought to determine which voxels were most predictive of a positive outcome, of an angle 1 outcome, what you see is that the best resections really favored and that was more anterior medial. And this, I think, for all of us who do a lot of this in the hippocampus, really has colored our tendency to point our trajectories a little bit more anterior. Before I saw the outcome of this paper, I had a tendency really trying to get everything, but really making a point of chasing this all the way out to the tail. And although I try to get that when I can, I really always make sure now that given a curved hippocampus, I will favor ablating the tip rather than having to chase the tail if I can't do both. I'm going to wait. There we go. Okay. So here's what that looks like. This is one of the systems that we use. This is a variation on the StarFix frame called the micro table. It essentially does the same thing with guides, a 4.5 millimeter drill. We use that same guide to insert the bolt and then insert the laser cannula down, through that bolt and along the hippocampus. And so how do you use this? How do you actually go about using this technology, and where does it fit in the realm of all the things that we treat with epilepsy? And so this is an algorithm that we've put together to sort of guide our decision making. And you can see there are a lot of steps that are not related to LITT. But in essence, you start with medicine. You say, okay, you have epilepsy, can you control that medically? In about a third of patients, you're unable to do so. And so with those patients, what shall we do next? Can we identify a seizure focus? If so, then we can go further and see whether that's a resectable focus. If it is, then resection or laser ablation are both options, and the decision really depends on the size of the lesion. So if you have a very large lesion, you find that you're having seizure activity not just in the hippocampus but out in the lateral aspects of the temporal cortex, that's more likely to require a full temporal lobectomy. If that area is small and well circumscribed, like the hippocampus or an area of heterotopia, laser ablation can be considered. Laser ablation has also been used in situations like, if you have a patient who has drop attacks and generalized seizures, it has been used by a number of centers in callosotomy, and it works very well for that. I was struck. I've done one patient with laser as opposed to an open callosotomy, and seeing that postoperatively a year later, it's dramatic just how complete a callosotomy it provides. It's quite impressive. Are there questions about that? That may be a good place to sort of see if there are questions, because this algorithm can be complicated.
His question is, could you talk about your experience with LITT based on corpus callosotomy? Is this procedure you think is best done in the traditional open way, or does ablation yield reasonable results like LITT for MTS? If so, how many trajectories do you feel is necessary to get a good anterior 2/3 disconnection?
Yeah, that's a good question. So, I think that there are a number of factors. To answer the question first, how effective is it? I would say that we don't know. To date, I think there are only a handful of published cases, one that we have published, a few others that are part of series of laser ablations. And so we don't really have a categorization of what are the results of laser callosotomy versus open callosotomy. Having said that, I've been impressed in the patient that we did, and it would be interesting in a future talk. I'll include that for sure. The effect of that callosotomy is extremely complete. We did a 2/3 anterior callosotomy. We did it in two trajectories, one sort of coming from the parietal lobe and crossing obliquely across the corpus callosum, and then the other treating the rostrum of the corpus callosum. It was at about 2 years' time, we had a follow-up MRI, and it was tremendously effective. You can see very clearly where the lesion starts and stops, and the corpus callosum is essentially absent with regression of the fibers on either side. As far as the outcome for that patient, he did beautifully for about 2 years. He went from having multiple daily seizures to having no seizures for a period of about 18 months. But in the last 18 months, he has begun to have periodic seizures. And so our plan is to go back and laser the remainder of that corpus callosum, which is often done when you do an open callosotomy. If you do the anterior 2/3, you find yourself sometimes going to take the remainder. So I hope that answered all those questions. I think it's an excellent technique. I suspect in time it will replace many of the callosotomies that are being done open.
Given the incidence of repeat procedure for epilepsy treatment, where do you see LITT versus resection fitting in an algorithm? Is it difficult to resect after LITT if patient remains refractory with further focus? Do you find resection will remain first line?
Yeah, that's a good question. It really depends. There are some centers that have shifted to, epilepsy at Emory, for example, I think has largely shifted, I believe, to a sort of laser-based technique. I think that there are definitely cases where your ablation does not work, and those patients are candidates for resection. I personally lean that way because I think once you have failed to achieve seizure freedom with a limited resection, to go back and make more limited resections, you may be chasing your tail a bit. At the same time, it is sometimes difficult to know if you ablate a hippocampus and the patient comes back and is seizing again after some period. I don't think that you can assume that it's simply the lateral temporal cortex that is the culprit, or more of the hippocampus that you didn't get. I think you are often obligated to pursue the question of, well, is it now the opposite hippocampus? Because a substantial percentage of patients who we think have unilateral hippocampal foci end up having bilateral temporal foci. So I guess my algorithm in essence is, if that first ablation does not work, typically to perform stereo EEG, confirm whether or not the remaining seizures are coming from the same temporal lobe, and if they do appear to be substantially coming from the other side, then you're talking about RNS. If they're coming from the side that you treated, typically then I would do a temporal lobectomy. I've got a few more slides here which I can go through quickly and then answer any more questions. I lost one there. Well, the previous slide that I've sort of fanned through, thank you. This is a number of different applications of laser ablation in situations of epilepsy, the most common being MTS. Focal cortical dysplasias have been treated very effectively with laser ablation. Hypothalamic hamartoma, there are a large series of these procedures, and that I think has gained some prominence in the treatment of that disease. Cavernous malformations, there are several small series. I have used that with some success, although I've also had patients that failed this and needed a subsequent resection. I think the challenge there is getting enough of the surrounding hemosiderin with your ablation to be sure that you've captured the seizure focus as well. Tuberous sclerosis has been used effectively if you can figure out which tuber is causing the seizure focus. People have paired a laser ablation with stereo EEG. If you find sort of a diffuse or region of activity with stereo EEG, you can use laser ablation to treat that. Again, it's a question a little bit of how much you have sampled with your EEG and how much you are planning to treat, because you sometimes have not been able to circumscribe it with your stereo EEG electrode. And that's part of the trick, is knowing what it is. I think it works best when you have a region that is suspicious, like an area of cortical dysplasia that you're sampling. And then finally, we've talked about the callosotomy, which I think is an exceptional technique. So this is a paper that we published about a year ago, looking at national trends in surgical resection. And so what you can see here is that the application of LITT to epilepsy is increasing from very few, 1 per 1,000 patients with epilepsy in 2012 to now about 5 times that. So there seems to be a steady growth of this technology, which I think it will only continue, and I expect will even increase in the rate of its application. What was kind of striking to us when we looked at this is just at the same time that we're seeing an overall decrease in surgery, and that was surprising to me, actually, because really this is an area where I had thought that the number of new techniques that we had were increasing our ability to treat epilepsy surgically. So that's something I think that needs to be watched carefully. It's a topic really of another talk, why that's happening and how we can sort of turn the tide on that. I think it's an important challenge for neurosurgery. And then this is another study that was just published. This was the epilepsy arm of that same Lantern study that was mentioned previously. This was just published by Patrick Landruzzi. in a series of about 100 patients, I believe, I forget the exact number, what we found in this series was that 64% achieved angle 1 outcome, and 73.8% achieved angle 1 or 2 outcomes. Again, there's a substantial evidence growing with multiple studies now that you can achieve really pretty close to what's been achieved with surgical resection for mesiotemporal epilepsy. And again, that was accompanied by significant improvements in quality of life. And as all these things, there's short hospitalizations, about 32 hours, most patients being discharged the day after their procedure. Okay, and I'll take any questions if we have a few minutes.
Yeah, you know, we're close to, we're a little bit over actually, but I do have 2 questions that maybe both or one or the other could answer that came in a little bit earlier. And it's, are you regularly using DTI for your trajectory planning? That's the first question, and then I'll follow up with the second.
Yeah, I imagine that might be suited to the tumor world there. I'll give you the cheater's answer and the real answer. So the cheater's answer is that I'm at a point now where I pretty much am getting DTI for everybody just in general. But that being said, prior to that, only if there were white matter tracks that I thought were relevant to the trajectory or to the burn. And you can import those. If you, let's say, have your brain lab, fiber tracking, you can bring those into the Monteris software, but they come as kind of a DICOM transfer. So they come as these kind of like white blobs. You don't have the same kind of color resolution where you get kind of blue for corticospinal, et cetera, et cetera. But you can import those objects into the screen and you can put them next to your lesion that you outline. And so you can see yourself cook up against a white blob, white matter track. So I haven't done that in every case, but when it's relevant, I do it. So yes, is the short answer. Not all the time, but routinely.
So the last question is, can you speak to the preference for pulsed versus continuous heating? Do you see more precise targeting with pulsed waveforms?
I can talk a little bit about that. I do think there are some advantages. I'm told, I mean, some of this is sort of a question for engineers and why it works this way. But in my personal experience, I think that the more gradual heating that you see with the pulse laser is useful. The lesion grows a little bit more predictably, and that allows you a little bit better control, particularly if you're using it with something like a directional sidearm. You can see it as it starts to progress in one direction and then rotate to apply heating to another part of the tumor lesion, etc. So I think that is valuable.
And I would just add that for the people who are really kind of engineering driven in the audience, it's not technically a pulsed laser, but it's a pulsed application of a non-pulsed laser. But it for all the reasons that Joe just stated, I think it does provide more control. It also, in theory, prevents some charring because you don't get as much overheating closer to the laser. So I think it allows for better control and better heat spread.
Well, let's go ahead and maybe draw a conclusion for this particular session. I want to thank Dr. Fecci and Dr. Neimat for their time and their expertise. And I also want to thank all of the attendees for joining and for asking terrific questions and for all the great discussion.